Our next speaker will be Dr. Hodics. She is our vascular neurologist and neuroimaging specialist and director of the Interventional Neurorecovery Program at the Department of Neurosurgery at Houston Methodist Hospital. She received her MD in Hungary and served as the director of the Stroke Center at Semmelweis University Medical School in Budapest. After a second residency at GWU, she received training in cerebral vascular neurology at Beth Israel Deaconess Medical Center, Harvard University, and became medical director of the Georgetown Stroke Service and Georgetown Stroke Support Group. She furthered her skills in stroke recovery and non-invasive brain stimulation at the NIH and received a K-23 Career Development Grant to test A-nodal TDCS in early stroke recovery. She designed and led several stroke recovery projects, including an AHA-sponsored grant and aid to study dual TDCS and VEGF in hemorrhagic stroke patients, and the first US-based VNS enhanced stroke recovery study at UT Southwestern. This pioneering work eventually led to the development of the currently only FDA-approved stimulation approach to enhance stroke recovery, which is the topic of today's presentation. Thank you, Dr. Hodics.
Thank you. Let's hope that my allergies are gonna leave me alone today. I have no relevant disclosures to make today. I will talk about VNS Enhanced Stroke Recovery, that is a newly FDA-approved application to improve recovery after strokes. At Houston Methodist, we are fortunate to have a multidisciplinary team, and I don't know if anybody is present here who has been trained in VNS recovery, maybe not yet. We are fortunate to be able to provide this groundbreaking new treatment for our patients. And if you remind me at the end of the talk, and if we have time, I might be able to share with you our first patient's 4-month results. As I mentioned, where is the hold? As I mentioned, the VNS is a breakthrough device that is designated by the FDA. And this is the outline of my talk. I briefly will touch on the recovery time frame and the mechanism of action of VNS. And then I mostly will focus on the clinical trials and practical applications. This time course of recovery is probably not a surprise to anybody in this room. A spontaneous recovery with rehabilitation slows over time and reaches a plateau after 3 to 6 months, as you can see here. However, that still leaves more than half of the patients with chronic deficits that have very few effective options to deal with. And in fact, unfortunately, impairments can worsen over time with significant deterioration in functional and motor outcomes seen after 6 months to 5-year period of time, which is roughly equivalent of the impairment level observed at 2 months. The next slide shows that this VNS application is certainly not the first use for implanted VNS. It has been already approved for drug-resistant epilepsy and depression. The device is very similar to the previous applications. The implantation is exactly the same. The implantable pulse generator is implanted under the skin below the clavicle, and the electrodes are tunneled under the skin to the cervical vagal nerve region, where the electrodes are placed around the vagus nerve. I would mention that there is one more FDA-approved VNS application, but that is not in the neck, but in the abdominal area, and that is approved for morbid obesity. So here in this and the subsequent few slides, I will briefly review the mechanism of action or the proposed mechanism of action, since we don't completely know all the components through which vagus nerve stimulation exerts its effects. The VNS paired with motor training enhances synaptic reorganization after strokes through release of plasticity-promoting neuromodulators such as acetylcholine, norepinephrine, and also actually serotonin, mostly perhaps acting through the attention system, which leads to neural plasticity improvements. And as you can see on the right side of the slide, rats that received a VNS paired with motor training, that is represented with the red bar, after stroke demonstrated a significantly increased corticospinal tract connectivity to the rehabilitated muscles compared to the equivalent training without VNS, that is the blue bar. CNS connectivity in both ipsilesional and contralesional hemispheres was found to be increased in these findings together, and of course a lot more that I don't have time to review here, indicate that VNS drives large-scale reorganization in the motor networks after stroke, which may underlie its recovery-enhancing function. And this slide will review just briefly again the vagus nerve stimulation dependent recovery of motor function in rat models of stroke. And as you can see, similar impressive results are seen across different models of stroke injury, including isolated cortical damage, which is this first slide, or cortical, subcortical combined damage, and I would highlight hemorrhage, very, very promising. Essentially, the results are the same whether the treatment was started early on after the stroke lesion or after a delay in the chronic phase. Surprisingly, it's not advancing for some reason, maybe? I don't know. Can we advance the slide, perhaps? Not sure why it doesn't move. Let's try it this way. Yeah, okay. Well, resolving some issues. So surprisingly, when investigators studied different intensity levels of stimulation, they found that more is not always better. The best effects were found with 0.8 milliamp stimulation. So let's see if it moves now. Okay, well, that's interesting. So this is a summary of all the animal models that used implanted VNS. And as you can see, the benefits are uniformly demonstrated across different disease models, including not just stroke, but TBI, spinal cord injury, and even peripheral nerve damage. And then now we're going to shift gears and focus on the human clinical trials. And as you can see, this is the general setup of the in-clinic therapy that patients received with VNS. And on the left-hand side, you see the therapist holding a push-button trigger that is connected through the computer to a wireless controller that controls the IPG that is implanted in the patient to stimulate the vagus nerve. The therapist pushes the button synchronously to every successful performance of motor task. And this pairing, by the way, is very important in terms of the effectiveness of the treatment. So this next slide shows you the in-clinic treatment, where the therapist activates the VNS during functional and task-specific therapy. These tasks should be, as always, salient and driven by the patient's needs and adapted to remaining challenging but achievable. Am I on 17 minutes already? Oh my goodness, okay. So the sessions are extremely challenging for patients. They are 90 minutes, which is much longer than the usual treatment length. And they are repeated 3 times per week, and each session is supposed to include at least 300 to 500 movement repetitions, which is much more than what the usual therapy intensity is. The in-clinic therapy was included in all 3 clinical trials that I will mention. And the out-of-clinic therapy as a home therapy addition was included in 2 of the more recent trials. In the home therapy session, it wasn't possible to directly correlate each specific movement with the stimulation. So instead, the investigators used the next best, which is the patient was swiping the magnet, and after swiping the magnet, the IPG was delivering every 10 seconds a stimulation pulse for the next 30 minutes, through which the patient performed relevant daily activities with the affected arm or exercises designed by the therapist. And I should mention that this treatment can be performed up to 4 hours a day. So these were the 3 clinical trials. The first 2 is a pilot trial. The very first one by Dawson and colleagues was from the UK originally, that used only in-clinic treatment and no at-home treatment. It was only a single-blind study, as the control did not have VNS implanted. However, the subsequent 2 studies by Kimberly and the pivotal trial, of course, actually had implanted all patients, and the sham VNS included even a little tickle during the beginning of the treatment to create similar sensations as the real treatment, so that patients were truly blinded to their assignment. And as you can see, they were all in chronic stroke patients with slightly different time frame, but very similar overall. And then the 2 latest trials actually included also a crossover for the sham patients to observe their response. And these are the clinical trial results, where just a question, how many are familiar with the Fugl-Meyer scale? So quite a few, that's wonderful. So Fugl-Meyer scale is an impairment scale, and here we use just the upper extremity component, where the worst score is 0, that is no movement, and 66 is the maximum score, which is essentially normal movement. I would also highlight that if you see an improvement in Fugl-Meyer scale that is more than 5, that is clinically significant. Not just statistically significant, but clinically significant. And as you can see wonderfully, in all these clinical trials, the treatment group, the VNS group, actually achieved clinically significant response, while the control group did not. And these improvements were actually present at the follow-up 90 days as well. The investigators reported also a very important measure that was not reported typically before these trials, which is the responder rate. Responder rate refers to the percentage of patients who achieved clinically significant response, which is, I think, if we think about it, is a very important number, and perhaps it should be reported after this for every studies, because as we know, there is no treatment that is optimal for everybody. And I think if we are trying to evaluate just an average effect based on those patients that perhaps don't have the genetic makeup to respond, perhaps we are underestimating the potential of the intervention for those patients that would respond otherwise. So here the response rate was very impressively, again, double in the VNS group as opposed to the control group. And if we want to summarize the results from this slide, I would say 2, 2, 4, which is not 4, but 4, which is twice as many patients responded twice as well, and the number needed to treat to have a clinically significant benefit was 4.3. Now, this twice as much improvement is further highlighted in this slide, where the highlighted area at the bottom shows the results from the clinical trials. The top ones are the animal trial results. And this is not 5 trials, this is 3 trials, but they also highlight not just the impairment improvement, but also the functional improvement. And then here now, we can see a follow-up post hoc subgroup analysis of the pivotal VNS rehab trial that was originally published in 2021, and this subgroup analysis in 2022, which shows consistent effects across a wide range of stroke survivors, regardless of age, gender, time from stroke, severity, site of stroke, cortical versus subcortical strokes, which is very encouraging. And here, an even more recent publication from Dr. Francisco from Houston, which actually shows the follow-up results from the second pilot study that I showed you before from Kimberly and colleagues. The original study showed that the crossover group that was originally assigned to the sham treatment group achieved similar improvements as the original treatment group. And the wonderful news was from these past years, actually just the past couple of months this came out, that these impressive improvements have not only been maintained, but perhaps even further increased. And I would say that the almost 15-point improvement in the Fugl-Meyer scale, if there are any therapists here that use a Fugl-Meyer score, you would say that's impressive. Furthermore, the participants did not drop out during the study owing to complications, intolerance, or lack of efficacy. And they did their home therapy religiously over the 3 years following the treatment, which is a testament to the therapy. And now we're going to see a few patient examples. This is a 69-year-old lady who obviously had still fairly significant impairment 3 years after stroke in her writing ability. And as you can see, it's an almost miraculous response from 8 weeks of VNS treatment. Of course, not all patients will experience such a drastic improvement, but it can happen. And these are some before and after videos from the clinical trial. The first one that you're going to see here is an average response that you can see with a patient. This is a 72-year-old patient that was 4 years after the stroke. And as you can see, the before is on the top. The task is to fold twice the towel and do it as fast and as accurate and as neatly as possible. So as you can see, the after performance, although you still see there's a significant impairment still, but it's much more fluent, right? And this is a 6-point improvement. So for those of the audience, that are not familiar with the test, perhaps, this can provide kind of a visual guide of what a 6-point improvement might mean. We are still struggling. Significant difference. All right. And now the next 2 videos are from the same patient, just 2 different tests. The first one is going to be a Fugl-Meyer assessment, which is an impairment test. And it's going to be a more gross movement evaluation. As you can see, this was the baseline. The task is to abduct the arm and lift the elbow to the level of the shoulder and turn the hand so that the thumb points towards the ceiling. And this is the follow-up. And then now we're gonna do the Wolf motor function test, one of the items, which is a flipping cards. The subject is supposed to grab the card and turn it over sideways, so they need to do a supination movement, one by one, and place it on the table. So this is the initial baseline.
So flipping it over and leaving it flipped.
I'm letting it run so that you appreciate the difference in the performance and the time frame. Certainly, this patient had a very dramatic improvement, which this is just to demonstrate how good of an improvement you can see, not that this is a typical response.
Okay, so start with the hand in your lap. Ready, steady, go. That's it. That's fine, just leave it where it is. Lovely.
Okay, I'm clicking, but it looks like it, again. Sorry about that. We did try this yesterday, it worked. I don't know if how about that? No? Would you be able to help us with the forwarding the slide for the next slide? In the meantime, while that's happening, for the sake of time, so the third assessment hopefully will be seen here, which is the most impressive one. Okay, I think we can go on. The last one. You would almost think that the patient didn't even have a stroke, right? It's quite impressive. Excellent. So then we're going to go over just briefly the eligibility. It's a little bit tricky. I would be happy to evaluate any patient and take care of the administrative requirements, et cetera, if you have any of these patients. These patients have to be ischemic stroke survivors having a moderate to severe hemiparesis involving the upper extremity and should not have any history of bilateral or left vagotomy. And the candidates should be able to comply with a quite vigorous treatment. And the treatment was found to be safe and well tolerated in chronic stroke patients. Essentially, most of the side effects that were observed were, as expected, pain at the incision site and bruising. There was one patient that had vocal cord paresis that resolved after a few weeks. No serious adverse events, and not even any adverse events were seen throughout the studies for holding antiplatelet and anticoagulation medications during the perioperative period. So this is again just a highlight, and just as a review, we overviewed the time course of usual recovery and recovery with VNS. We reviewed the mechanisms of recovery and the clinical trials and practical applications. Again, the pivotal VNS rehab trial involved 108 patients in multiple centers. It was a randomized, sham-controlled, triple-blind therapy involving 6 weeks of in-clinic and then a follow-up home therapy, and the control subjects were crossed over to receive paired VNS. And the summary of the results, again, was there was statistically and clinically significant improvements that were also achieved in the crossover matched VNS group, and in the pilot study at least, where there was an opportunity to observe over 3 years after the completion of the study, the improvements were maintained, and the number needed to treat was 4.3. So the effects of paired VNS were consistent across a wide range of patient groups. And thank you very much. This is my references, and I don't think we have time to discuss the patient, but perhaps later. Thank you.